Hello doctor. A patient is admitted to ICU with GI bleed. Should I keep him NPO or start feed?
It's a complicated question. Okay, let's see the answer in this video. 3 reasons why we are scared to start feed. First reason is preventing decrease in intragastric pH. Food is expected to cause acid release and lower pH. But with PPI therapy now a norm, this fear is passé. The potential for shear forces to dislodge newly formed clot or recently placed clips or bands also contributes to the predilection for fasting. However, harmful shear forces arising from food or the presence or placement of a nasoenteric tube is not supported by the current literature. Food can increase bleed by increasing the splanchnic blood flow. Animal models corroborate that enteral nutrition increases splanchnic blood flow, but they also demonstrate increased gastric motility and improved mucosal integrity with enteral feeds. Table summarizing randomized controlled trials evaluating timing of feeding after bleeding from ulcer disease. These 4 studies found no difference in early versus late in terms of bleeding-related complications. Similar 4 RCTs in variceal bleed also came to same conclusion that early feeding is not affecting the rebleeding risk. There have been no trials on bleeding risk of feeding with stress ulcer and lower GI bleed. However, most studies have found benefit of early feeding in these cases. Factors favoring early feeding point to the potential to shorten hospital length of stay, reduce treatment costs, and decrease associated risk for nosocomial infection. The other factors are the established use of PPI, improved endoscopic therapy to control and reduce risk of re-bleed, and the fact that early nutrition protects the mucosal integrity and prevents stress ulcer. Patients with GI bleeding associated with gastric erosions or stress-related mucosal damage, gastritis, Mallory-Weiss tear, esophagitis, angiodysplasia, Forest 2C and 3 ulcers and lower GI bleeding in general are recommended to resume feeding following endoscopy without delay, as these bleeds tend to be self-limited and rarely require intervention. For higher risk, Forest 2A-2B, lesions, data remains mixed on the safety of early refeeding. All trials to date have been relatively small scale and not implemented current standard of care practices using combination endoscopic therapy and high-dose PPIs. Until those studies are performed, patients with high-risk lesions will likely remain NPO for at least 24 hours following endoscopic intervention. Give us a like if you find our videos helpful. Patients with bleeding esophageal varices who undergo esophageal band ligation, vasoconstrictor therapy, and antibiotic prophylaxis and who are able to have volitional intake can likely resume a clear liquid diet immediately following the procedure. However, timing to advancement to a soft diet should not be delayed beyond 48 hours following the index procedure. Thank you.